Live. Who's connecting now? Who's going to open it?
Ordinators on the other side is the administrator.
Okay. So am I audible?
Yeah, you should be. But we will be starting probably at 12. Yeah. But they are
Okay.
Good. Those at the end.
Okay. Thank you. Sorry. It seems there's a lot of Monday in this week. This must be me. Oh, okay. It's like so hard. So hard to get. You refuse to see some. I can think yes, I'm touching this thing.
Dr. Norikira, we've got people online as well, so it's now 3 minutes past 12. You can just say when you want to start.
Okay. So have you welcomed the guys online?
Dr. Norikira, nobody said anything to the people online. So you
Can
can
you
stop
hear
sharing
me?
and then you can take the meeting from here.
Okay. I don't show, but it's fine. I think they can hear my voice. Good afternoon, colleagues, or good day, colleagues. We are about to start. I'm welcoming the colleagues in the room and the colleagues online. We are about to start. I think we were just waiting for one more of the speakers. And then we will start in the next, give us 5 minutes, we'll start.
It's not changing. Oh, yeah. Yes. Is Jack in? Is Jack in?
Is there only one platform?
Yeah, there's two platforms.
There's two platforms. Yeah, if you want to write in request. Yeah. I don't know who's the second one.
Colleagues, welcome. I think let's start.
Yeah, okay.
Welcome to the summer press briefing. I'm Dr. Mzulungile Notigida, the new CEO of the South African Medical Association. We will be taking you through the conference, which is starting tomorrow. And we have Dr. Adebe facilitating this press briefing. Of course, we will start by hearing from the chairperson of the association, next to me, Dr. Mvuyisi Mzukwa, and you will hear from Prof. Dai and Prof. Jack, who's going to join us. Thank you very much. Let me hand over to Mr. Adebe.
Thank you, CEO. CEO has just taken my first job, but at least that's how new improvements sweep. They sweep fast and quick. So essentially, the CEO is supposed to just give us an outline of what the conference is about. The chair will come in, and Prof. Ness will also come in to unpack the full details of what we are doing. So without any further ado, can I just send over to the chair and the CEO to do the initial briefing of where we're going with the conference.
Okay. So the chair will be doing that. The chair will cover the overview of show. Chairperson.
Thank you very much, Dr. Bandile Hadebe and Dr. Notigida for the introduction. I am Dr. Mvuyisi Mzukwa. I'm the current chair of the South African Medical Association. I would like to greet you all, those that are with us here and those that are online. Well, we know that South Africa is on the brink of a momentous change in our healthcare, in how it is procured, funded, and reimbursed. The NHI is a piece of legislation, as we all know, that not only impact health professionals, but everyone in this country. SAMA has, on various platforms, made its position known that as doctors who saw on oath of service to those who seek healthcare from us, we do not believe that this bill will achieve what it purports to do. And we must also know that SAMA fully supports the universal health coverage principle. However, we do not believe that this will be achieved in South Africa through single purchase, single payer system as articulated in the bill. Now, this leads me to the 2024 summer conference to be held here from tomorrow, the 15th of February, 2024. It's themed towards strengthening health systems, which would be held here in at Sandton ICC, starting tomorrow, as I said. We believe that any form of health reform must be based on a health system that is built on adequate human resources for health, access to essential drugs, medicines, vaccines, sustainably utilizing evidence-based policies, ethical leadership and governance, as well as built on digital and technologically integrated systems. These elements, or these are the elements of a resilient healthcare system, capable of meeting the needs of the population itself, able to weather future pandemics, disasters, and other public health emergencies. And our mission as the South African Medical Association is uniting doctors for the health of the nation, which speaks to the commitment to this country and its citizens, as well as ensuring that we are future-proofing our healthcare systems, contribute meaningfully towards building its resilience, and providing equitable access to quality care, regardless of affordability status for everyone. This conference is more than just a meeting of minds or just an opportunity for networking or collaboration. It is a call to action for all stakeholders and our delegates to come together and participate in meaningful dialogue that will create the health system we want, including refining future policy engagements. The 2024 Summer Conference, as a landmark event, will present a platform for knowledge sharing among medical professionals, working at every level, bringing together experts from a wide variety of healthcare fields to contribute to influence and reflect on the policies that shape our medical landscape. Now, this is an invaluable chance for doctors and other health professionals to strengthen their strategic networks and reinforce sector-wide collaborations and high-level conversations about how to advance quality healthcare coverage as a fundamental human right. We truly believe the sense of community and solidarity results in strengthened workforce. And you can see in this in South Africa's doctors and healthcare workers who are exceptional in what they do and benchmarked against the best in the world. Our health professionals have achieved impressive results, even working within the context of the South Africa's resource-constrained national healthcare system. As you know, the Department of Health has confirmed 1,500 vacant and unfunded posts in the provincial department across the country. The Minister of Health yesterday, during the debate of the SONA, committed to work with us in finding solutions for the unemployed doctors. We have always pledged our support and willingness to work with the ministry. Now, the South African Medical Association works for the preservation of the medical profession through these initiatives and activities with various stakeholders, building the resilience of our healthcare systems to withstand the challenges that may come, including that of unemployed doctors when we need them on the field, active participants in the health policy that shapes our industry, and be a critical voice for those who walk through our places of work, needing our services and care. We extend our heartfelt thanks to all the event facilitators, our speakers, our attendees. Your contributions are helping to shape the future of our healthcare. So I would like to take this opportunity to thank you for your attention on behalf of the South African Medical Association. Thank you.
Thank you, Chair. I'm going to ask the CEO to expatiate a little bit more of detail. Yes, Dr. Theo.
So the next speaker is going to be Prof. Jack Snyman. Prof. Jack Snyman is going to just outline what will be happening on the 15th, because we will be also kickstarting this conference with a coding conference. And Sama has been a leader in that space. And Prof. Snyman will unpack what actually coding is. We view it as the pulse of healthcare funding, and especially with the new changes that are coming in, we want to be a serious player in the space of coding. So I'll hand over to Prof. Jack Snyman.
Thank you, Dr. Nodikida. Thank you for the opportunity. And I think we kickstarted the 2024 conference with obviously a coding half-day conference, followed then by a 2.5-day SAMA conference from the Thursday afternoon onwards. Now, why is coding important? Coding is globally important to identify the disease, the procedures, the equipment, the devices, and even the medicine used on a patient. Now, why is that important? It's important because that helps you plan, gives you statistics, it gives you data, and you understand the healthcare of people that you work with, and you can fund it appropriately, and you can also create and scope the ways that you fund healthcare. And that is healthcare, whether it's in the private sector or whether it's funded by a state sector, anywhere in the world, you rely heavily on the coding aspect in order to make the correct decisions going forward and collect the correct data. So that's why SAMA, I think, being the custodian of the coding schemas, is utmost important for the country, and therefore we had this conference to make sure it's up to date and it informs. So what we will follow on with the coding, as I said, is that 2.5-day SAMA conference. It varies from, let's look at what it focuses on: sustainability and healthcare in South Africa. In other words, it will move from complete what is healthcare to what is the research in healthcare in South Africa. So we will do pandemic prevention, ethics in healthcare. We will look at new digital innovations in healthcare. How do you use data? What is real world data? How does data inform decision making? And also how doctors interact with patients and how doctors survive all of this, looking at the mental health and sustainability of doctors going forward. So we've invited both international and some of the country's distinguished medical professionals who will be sharing their insights and their years of experience and research in these different fields. So we've got keynote speakers such as Dr. Imta Suleiman on the first day telling us about the ethics within healthcare and what is our responsibility as healthcare workers within the bigger scope of things. Dr. Masiki, the HPCSA registrar, Prof. Evans from the UK, looking at data, looking at the experiences within the UK and how that can translate into practical solutions in South Africa, right where we are now. And obviously our own SAMA president, Professor Gabe Boffard, to also introduce our first day, our really making it a really good intro session. There will be informative sessions spanning, as I said, multiple conversations. And I think it's important to say this is not a droning on of slides that people have become accustomed to over years. We've changed it. It's short presentations to the point, and then a nice interactive session, almost a debate on what is it really that matters to the patient and the profession. So, as I said, from real-world evidence to non-communicable and communicable diseases, right into the data and how that is put into practice and how does it inform decisions going forward. So then, obviously, as I said, a much anticipated session on funding of healthcare. Now, this is from your private sector. How do we fund in the medical scheme environment to how do we fund from other environments such as the government, and also where we think there's an opportunity to have alternative reimbursement models for procedures and for medicines, and how we can use that opportunity to get greater access and equity within the South African environment. So our concluding session, as we said, we're looking at the health of doctors, and we're also looking at the criminalization of the medical profession. This is not a South African phenomenon. This is a worldwide phenomenon. And how do we assist our doctors in actually doing what they're supposed to do, doing it well, without necessarily being exploited also within this legal environment? That's sort of the highlights of the conference. And we also obviously look forward to unveiling new research and the abstracts in that particular abstract session, which gives younger doctors also the opportunity to showcase their research, what they are busy with. And then obviously our programs on the web, please go, it's up to date, and avail yourself, and please contact us for any further information.
Thanks, Prof. Dr. Nottingita, can I just ask you to get closer to Dr. Mzoka from the shot? I mean, the guy's struggling to capture the pending shot. Are you able to move closer?
That's as close as I can get.
Let's see.
So the next part, colleagues, is a very important part. So SAMA as a National Medical Association also participate in global health issues and international platforms. It is the only medical association that is recognized by the World Medical Association. And it is through SAMA's participation in that space of the World Medical Association and the global health issues that the WMA then decided that SAMA should host the regional meeting on the Declaration of Helsinki. So the next speaker, who is Professor Amesdal, is going to talk to you about that conference, which starts immediately after the ending of the summer conference on Sunday and runs all the way into Monday. So without further ado, let me hand over to Prof. Amesdal.
Thank you, and it gives me great pleasure to outline briefly SAMA's global footprint and the impact it has on the international arena. As the only internationally recognized medical association in South Africa, we as SAMA actively participate on global health issues. And it was through this international global health participation that the World Medical Association recognized SAMA's work and decided that the regional meeting on the Declaration of Helsinki will be hosted by SAMA this coming weekend at Sandton ICC. And for us, it is a great honor to host this regional meeting on the revisions of the Declaration of Helsinki. And we look forward to providing a platform for a uniquely African perspective to potentially inform revisions. So what is this Declaration of Helsinki? It is a set of ethical principles regarding human experimentation and research developed by the World Medical Association in 1964. And it's been revised several times since then. And the reasons for the revisions is because of the rapid advancements in science and technology, which actually impact health research and health. So as the science and technology evolves, so must ethics and the law keep up with this evolvement. The Declaration of Helsinki, I can assure you, is regarded as the cornerstone document of human research ethics globally. The Declaration of Helsinki is particularly relevant to Africa as a continent because of the many health challenges that we have. And, just to name a few, we have a high burden of infectious and non-communicable diseases. And look at our resources. We're a resource-limited region. We do have infrastructure, but our infrastructure is also limited. And just reflecting on our history, Africa has been steeped in a history of colonialism, and within South Africa, a history of apartheid and exploitation. And these challenges have implications for the conduct of human research on our continent, and in particular, that of safeguarding the rights and interests of human participants. as well as for the participation and benefit of African populations in global health research, so that no one is left behind. Africa cannot be left behind in terms of global health research. Therefore, there is a need during the review and revision of the declaration to ensure that the current and emerging ethical issues and the best practices in human research, as well as the specific needs and context of Africa, are included as well. The World Medical Association is currently revising the declaration for its 6th anniversary of its adoption. And it's established a work group to lead this process. And I can proudly say that SAMA is included as a member of this work group this time round and in the previous declaration revisions as well. So you can see SAMA's international footprint. The work group's efforts are informed by regional and topical meetings, which are spread over 2 years, where issues are discussed by local and international experts and engage audiences who have diverse opinions. The regional meeting, hosted by SAMA, will provide an opportunity for African stakeholders such as researchers, ethicists, policymakers, regulators, civil society, and community representatives to share their views and experiences on the declaration and its implementation in Africa, as well as propose suggestions and recommendations for possible revisions. The meeting will also foster dialogue and collaboration amongst African countries and regions, as well as between Africa and the rest of the world. And this will be on the ethical aspects of human research. We hope that the regional meeting provides an opportunity to better understand the declaration and its relevance to Africa, critically assess the strengths and weaknesses of the declaration and its application in Africa, identify the key ethical issues and challenges facing human research in Africa, formulate concrete and feasible proposals and recommendations for the revision of the declaration in Africa, and strengthen the African voice and contribution to the global revision of the process of the declaration. We in SAMA, we believe that the meeting will contribute to the overall goal of ensuring that the Declaration of Helsinki is a living document that respects the dignity and rights of all human beings, including all of us in Africa, and that promotes the advancements of science and health for the benefit of humanity and the global community. Thank you.
Thank you very much. Thanks, Bob. Before we hand over to the press for Q&A session, I'm just going to double click on a couple of points that have been raised so that we crystallize our conversation. I'm going to start with you, Chairperson, Dr. Mzluga. You've touched on a couple of issues, but with regard to NHI, there is a systemic point that you're raising beyond just the human resource challenges that we currently are facing. Can you just broadly unpack what are those systemic issues that really have to be fixed before we, dive down into the implementation of NHI? Dr. Mzluga.
Thank you so much, Dr. Hadebe. If you look at the World Health Organization, it talks 6 or 7 pillars of a healthcare system. It talks about finance. It talks about human resource for health. It also talks about issues of around medicines, vaccines, and also technology, infrastructure. It talks about leadership and governance. So you've got to, if you are talking about a reform, you've got to talk about all those things. And we know through the previous health ombud, Professor Makgoba, he spoke a lot about the lack of governance and leadership in our country, especially as it relates to healthcare. So you can't just think that you are fixing a system if you're only fixing that part. Recently, have you noted in our presentation now, there's a couple of hundreds of doctors who are not employed, and you cannot come up with a system where there's dire shortages. As we know, at this point in time, the ratios in the public sector is 0.35 doctors per 1,000 citizens, compared to the private sector, about 1.75 doctors per 1,000 citizens. So if you look at those disparities, we've been informed of babies put on the cardboards and all these things. So the system is not ready. But also you've got to consider other social determinants of health. Like I always pointed out, if you don't fix water in the municipalities and all these other things, you can't expect to have a health system that is reformed. The government must be a one system that each department of in government must speak directly to what is happening in healthcare. For example, spatial planning, when it comes to town planning, stuff like that, it must talk to people being able to exercise and all these things. So that's not what we see in South Africa. So there's all these systemic issues that have not been addressed, and you can't think that just pouring in funding is going to be a silver bullet, as they put it, for the healthcare system.
Thanks, Dr. Mzulu. Can I also just ask you to touch on recent surveys that have been conducted by some amongst its membership, looking at their sentiments around NHI? Who's going, who's staying? What is that feeling? Because some are actually represent thousands and thousands of doctors in this country. What are our surveys coming up with?
Well, like the previous surveys that we've done, even this one, a majority of our doctors, they really have not been taken into, they are really not sure. There's no certainty around how the NHI is going to work. And they're pointing out obvious issues. Like I said, issues of governance, but also their working conditions. Their working conditions are in a dire state. If you look at junior doctors being attempted to be raped by outsiders, the lack of security in the workplace, and also someone has conducted another study that shows that our doctors in South Africa are underpaid. In fact, the salary that they're getting now is the salary that they're supposed to get in 2015. So our doctors are underpaid. I heard, people talking about these huge salaries that doctors are getting. And we're talking about, the basic salary of a doctor. We're not talking about other things like overtime and stuff like that. If we talk about just baseline, we are far, our doctors are underpaid. So hence we are saying to government, if you want to retain these highly skilled professionals who are sorted, by other countries, they are highly sorted by other countries, you need to invest in them in terms of attending to their conditions of work, but also reimbursement.
Thanks, Dr. Mzulu. Can I just ask, when I double click on some other issues, please don't look this way for the sake of the camera. I will be asking, I know you're answering me. Prof. Guy, I wanted to just double click on the issues that you were raising around the Helsinki Declaration. But step back, just one step back. So we're discussing, the bioethics of how things should be done when we're doing human research. But when are we discussing the contribution of Africa into the global research conversation before we speak about framework? I mean, we're sitting with a 25% contribution in terms of genomic pool within more than 25% of the genetic pool within Africa, but our contribution into R&D is about 2.5%. When are we driving that conversation from what are we building that framework for, but the what? How are we getting involved in that research conversation so that our output and our contribution into how therapies are produced is guided from an African perspective?
Thank you. I think that's a very important question. And it is an ethically charged question as well. So when you look at the Declaration of Helsinki, and you look at the different articles within the Declaration of Helsinki, you will see there is this push for equitable access to research and also equitable access to research benefits as well. And this is the drive that we would be having from South Africa and Africa, using our Declaration of Helsinki to drive the equitable access to research across the globe. I think that is really, really important, because currently what we see is the 80-20 divide, where most of the research is done for 80% of the world's global privileged. And only 20% of that research is for the rest of the world, that is the low and middle income countries. So there's a lot of work going on pushing for equitable access to research, and also distributive justice, where we say the benefits and risks of research must be distributed equitably globally throughout the global village.
Thanks, Prof. Prof. Snyman, can I just come back to your issue? When you said coding in 2024, some people might be thinking about software development. Can you just unpack what kind of coding we're talking about? And also touch on DRGs in terms of a pricing regime and a budgeting perspective for NHI.
So coding is, as I said, the heart of the data that you will use to make decisions on. Now, coding is not new. Coding has been here for ages. Maybe over-exaggerating there, but forms of that. So coding is to make sure that there's some uniformity in data, so that you can extrapolate from that data into other environments, and that you can use the data not only for funding, but also for research going forward. So globally, there are uniform coding systems to a certain extent, but they're often also area or country specific. So the NHS in the UK has a very specific coding system. The North America's used, for instance, for procedure codings, would use CPT codings. Asia, if you go to Singapore, would use TOSP coding. And then you've got many countries that use no coding at all, and it's free text. And that, I can honestly say, is a complete nightmare, because you don't know what you're funding, you don't know what the patients suffer from, so you can almost do no planning unless you go into text. So coding is key to, as I say, making a funding decision, but it's also key to making a data decision in terms of the research going forward. So you're talking about DRGs. So how do you start with a DRG? So let's unpack that first. What is a DRG? It's a designated grouper of a procedure or of a disease which you want to fund holistically. So why do you want to do it that way? You want to do it that way to also get to a more equitable way of funding, so that you transfer a little bit of risk over to those who provide the service, but you also accept some of that particular risk. But in order to do that, you need to be able to, for instance, bundle a procedure appropriately. Now, a simplistic way of seeing it is, say, for instance, a hip replacement. You can say a patient that fulfill the following criteria with the following diagnosis. Again, now you go to ICD-10 coding for the diagnostic coding, and you add the CPT codes in a bundle, and you bundle with that now certain hospitalization stays, length of stay, levels of care, and so forth, which then makes up this particular bundle of care that the patient needs to receive in order to be functional again. So you can do that across this spectrum of healthcare services. It doesn't necessarily have to be that type of procedure, but sort of repetitive procedures initially will lend themselves a lot better to that. For instance, if you look at cataract surgery, as I said, the joint replacements, even if you go into oncology, if you start looking at episodes of care for breast radiation, for instance, there's no reason why that can't be a DRG going forward, because it's well defined, it's well described, the costs and the procedures around that it's well known. So it's not that you are going into the unknown. You will go into the unknown by researching, and the research will then tell you what type of coding schemas you need to go forward in these DRGs. So clearly in any funding system, whether the funder is the government within the NHI system, whether the funder is an insurance company, or even if the funder is out of pocket, a DRG will lend itself to have a better understanding of what I'm paying for. So in a nutshell, that is why we need this coding certificate.
Thanks, Prof. So I wanted to clarify that we're not talking about software development there.
No.
Dr. Theo, can I just come to you probably before I hand over and ask a couple of questions from you. One, I think there's a balancing act as leaders in healthcare that we have to strike. And so there's things that work in the private sector, there's things that work in the public sector, there's things that don't work in the private sector, there's things that don't work in the public sector. Now, one of the things that pointed at things that don't work in the private sector was the HMI, the Health Markets Inquiry, that was produced by the Competition Commission, having been, commissioned by the Department of Health. And it made significant findings in terms of how under-regulated the private sector is and how that influences our pricing regime as a country. What is the advocacy that should be happening around the recommendations and findings of the HMI? And how is this conference going to start galvanizing that? Because it was released, I think, in 2015, and it's now collecting dust. And it has very significant findings. What is that thought, CEO?
Yeah, so one of the reasons why Summer chose this particular theme of the conference, that strengthening the health system, was to make sure that in the conference itself, we look into all the weaknesses that exist within the South African health system, and also the strength that exists within the South African health system. So one of the things we're pointing out is that inquiry. What is glaring is that within the private health sector, there is a lack of regulation. Now, if that space is not regulated well, and who is responsible for making sure that that is regulated? So we need to answer that question to say, there is a responsibility within the state to make sure that that space is regulated, that there's laws there that are in place to make sure that it's regulated. And if you look at some of the things that Sama has been involved in within the same space in the private sector, there was once a complaint from some of our members around this racial profiling of merits. And we dealt with that as the association. So there's so many things that are happening in that private space that needs to be attended. So we, as Sama, as the chair, has outlined that we are very, very willing to work with the state to make sure that we bring in the measures that are supposed to be put in place there. And you'll be pleased to say that even myself, in my 7 days at SAM, one of the first meetings that I had was with the Board of Healthcare Funders, because I just needed to understand that space. What are the things that are they putting in place to make sure that corruption in that space is also managed? So we've agreed in principle with the Board of Healthcare Funders that we're looking into having an MOU between ourselves as an association that can look into that space so that we can deal with some of the problems that exist there. So that's in general one of the reasons why we chose this thing. I mean, I cannot talk about what is happening in the public sector. I mean, it's out there. It's clear that some of the planning there is a problem, and that also needs to be fixed. And I think if there's one thing that the country has done well, it would be us going back and looking during the COVID-19 pandemic, where both public, private came together and tried to work, and business people came together. That time was a very important time. So the conference also just looks at seeing how do we leverage some of the positives that came out of the pandemic period and we can plug them into an alternative blueprint for the South African health system.
Sure.
Thank you.
So one of the things that Professor Neyman was saying is that this is not just a talk show or a presentation of slides. It's a critical engagement platform that seeks to shape the future of the country. Where do we go with the resolutions that Summer is going to arrive with? How do we cascade them further? Who do we engage? Who do we submit what to? What is the end point of the discussions here? Tied to that, how do we use this conference to improve the relationship with fundamentally government, which sometimes seems to be running away from healthcare professionals and healthcare leaders? How do we use this conference as a stepping stone to get closer to that reality?
So one of the things that we've done, and we're very happy that the ministry, even yesterday, the minister announced in SONA that they are really willing to work with us, is to make sure that we actually invite the minister. So the minister will be addressing the delegates on I think on the second day, right? And if you look at our delegates, we've deliberately made sure that it's spread across both the public and the private sector. We've got experts from both sides, and we recognize our responsibility as the National Medical Association that it is upon us to bring the players together under one roof. Now, we aim to, beyond this, create a platform where both public and private players can come and engage the state, because we cannot, one of the weaknesses in how we've approached what we've been talking about is talking across each other. So we want to create a platform beyond this, where the Medical Association leads all these players and government, put them in one roof, and then we talk about this alternative blueprint for health care in South Africa, without necessarily saying that we will remove medical schemes or this one doesn't work. We just need to find one solution that works for the people of South Africa. And underlying that should be the innovation in technology and the use of AI, which is where Prof. Dai comes in as well with ethics. That how do we then bring in all these developments, but without undermining the fundamental principles of ethics in healthcare? So that's where we want to go.
Thanks, with the can I hand over to Jenna's? I've hogged the platform for too long, but I was hoping that it's going to extract additional information that you can cover when you go to print and publishing. Any questions? I'll take that one. Come here and finish there. You go ahead.
Hi everyone, my name is Arissa. I'm a journalist from Netwerk 24. I have spoken to you, sir, on the phone various times about this, about the unemployment of doctors. I've spoken to various doctors as well who've said that the problem is that at this stage they want to specialize, and they can only do that through the state. So I want to hear from SAMA's side, are you advocating at this stage that they can do this in the private sector? And I also want to hear from you with regards to funding. A lot of students have said that they have been placed, they have gotten their placement forms, but they have not gotten an appointment letter. So on paper, it looks like they are placed, and the minister is saying they are placed. But in practice, these guys are still sitting at home. They're not able to do their community years, their internships. So with this problem, if you could maybe comment on that, and also on the background of NHI. How does this influence NHI, and also a lot of doctors wanting to go, wanting to go overseas, especially to Ireland, seeming to just welcome South African doctors with open arms at this stage. Thank you.
Okay, thank you so much. I believe I should be taking the question.
A lot.
Yes. No, you're correct. You're correct in terms of your utterances. One, regarding the issue, maybe let's start with the issue of unemployed doctors and also the training of these doctors in the state. One, you are correct. At the moment, it is the state that is allowed to train specialists. But as you know, the state is struggling in terms of financing and funding of that space. It is a necessary conversation that must happen between the private sector and the state. Because to me, it does not make sense that you would not allow the private sector to be training. But also, this is linked to the poor regulation of the private sector. You can't just willy-nilly give the private sector, such a huge responsibility without that framework of regulation. So it's quite critical that there's a dialogue between the state and the private players. So that needs to happen for us to go forward. But also, if you look at, the doctors that we have, these are young doctors, they want to specialize, some of them. Some, they obviously want to contribute to the health of this nation. If you talk to them, most of them don't want to go abroad. They want to serve their communities. Remember this, but they've got families, they've got other commitments in the country. So, but the South African doctors are highly trained. So they are sought after by many countries. So it is important for the state to recognize that if you don't give a chance to these doctors, to practice in South Africa, ultimately they will leave. They'll go to other countries. It will be a sad day in South Africa where we allow these young, innovative minds to leave our shores and go abroad and advance other countries, having used taxpayers' money. We have paid as taxpayers for these doctors to be trained. So it can't be that we allow them just to live like that and say when there's obvious shortages on the ground. So those are the issues that I think we need to outline even in this conference and also in our future engagements with the ministry, to just make sure that they understand. I mean, there's a rhetoric that is always out there that healthcare workers are running to the private sector and they're leaving, the public sector and stuff like that. But it's disappointing at times when you hear, authorities pushing them towards the private sector and saying, no, we can't accommodate here, but we can take you to the private sector. The private sector that is serving 15% of the population and leaving the 80% unattended to. So it is, in the interest of the association to be pointing out these issues, backed by research, to say that we do need resources on the ground. It impacts negatively on the NHI. Hence, we are saying the system is not ready for the NHI because of these controversies that you see on the ground.
Thank you.
I just wanted for the record that I think it's important to clarify internship and consent. All these doctors that are struggling now are post-consent. So some has been working with the Department of Health to make sure that there are no problems with the internship and the community services placement. Now, we know with some that there was a problem in one hospital. We were reported that there was a problem in one hospital in the Eastern Cape, where the doctors were not captured for the interns were not captured for their rural allowance and other accruing benefits. But in terms of placement and appointment letters for internship and concepts, we have worked with the department to make sure that this year there is no problem in the placement. And we aim to do the same. We actually propose to them that if possible, we are available, our team is available to work with the human resources so that we make sure that there's smooth placement, because we know these doctors are in med school now who are going to qualify. So just to clarify that the ones who are struggling are post-concept.
Thanks.
Thank you. My name is Kumoja Mabenane. I'm from Flower FM 987. My question is, what kind of youth participation are you expecting during the conference in terms of the discussions that you're going to be having? My second question is with regards to NHI. You spoke about the systematic issues that are in the bill as it is now, and you've spoken about the surveys that you've conducted. But at this point, is there anything that you can do legally to stop the bill from being signed into law in its current form? Thank you.
Anybody can jump in?
Okay, maybe let me just take the easier one. Well, we just hope that, first of all, we know that we can't stop the president from signing. It is the prerogative of the president to do that after assessing the bill, and obviously we use legal resources to look at it. But we were hoping that the president is going to send the bill back to Parliament to say, point out the issues that have been pointed out by many other stakeholders, concerns, deep concerns that have been, pointed out. So it was our hope that that is going to be the case. But I must assure the nation and the president that we are also looking for a pen to instruct our legal department to, when we're signing out the instructions, to follow up on this after the bill has been signed. We're also looking for a pen. So I hope we're not going to get to that. The president still has the opportunity to send the bill back to Parliament whilst he's still looking for a pen.
Anybody want to take the second part of the question?
Yes.
Yes.
The youth.
Can you just tell them about the youth participation?
So I just want to also proudly announce that SAMA is actually launching its Women's Wing at the conference. So we're going beyond youth, but we're also looking at women issues as well. And amongst the issues in terms of the Women's Wing is we're looking to see how doctors and medical students actually get protection based on the gender discriminations that we see throughout our training career, both as undergraduate students and even once we employed as doctors, and also once we training to be specialists. And there are still some draconian issues that have to be addressed, and SAMA's going to take the lead in that. Now, as part of our activities, we also felt it's so important to get the youth that are from disadvantaged school areas to actually get some exposure at the conference and also participate with us. So we bringing across young girls, because it's a women's wing, we've called across young girls from a high school in Pretoria. And these girls are actually interested in science and the science stream. And we are going to have them not only at the networking lunch that we're having for the Women's Wing, but they're spending a full day with us, and they're going to get exposure in terms of ethics and advocacy and ethical leadership and ethical governance, because they're attending our very first session on Saturday, a full morning, which is devoted to ethical governance and ethical leadership. So we'd like them to start thinking about these issues now. They will then have time to interact with us in the break that follows. So this is the youth from the perspective of non-medically trained. But we do also have young doctors that have signed up for the conference that fall under the category of youth. So we will be having participation from the youth at the conference.
So one of the categories within SAMA is Junior Doctors Association, which covers the interns, so the first 2 years and the Cosmos, and plus 1 year post CSO, and those are also participating. So that particular structure, through its representation across the country, is also participating in the conference. So that's where we tick the box of youth from the conference perspective. Yoli?
Good day, everyone. My name is Yoli Swap from News 24. So my first question was going to be on unemployed doctors, which was covered by my colleague. And then the second one, I just want to know from SAMA, according to your survey, what are the challenges that are faced by public health facilities, and do public health hospitals meet the requirements of the NHI statement?
Okay.
Guy, why are you shaking your head?
All right, maybe let me just take this one. Well, talking to our members, obviously we get this feedback from our members, that the state of our hospitals, because they deal with that on a daily basis. And the issue of shortages of staff leading to burnout, the issues of unavailability of power, interrupting very critical surgery or operations, and also the issue of broken equipment, where you find that actually it takes months, to attend to this because there's no SLA in place, and there's many other challenges. The unavailability of medicines is a very crucial one. At times we've got emergency conditions that need specialized medication, but we can't find them at times. So it is there that we see the system that is not ready, for the NHI. And the issue then becomes very dire if you look at the rural parts of the country, where you find that, there might be some hesitancy because of the conditions. Some colleagues not keen to, work in such environments. But also we've seen conditions changing even in the urban areas, where you find that, there's sewer running in the hospitals, there's poor maintenance, there's even poor lighting of the hospitals, all these things that are impacting negatively on the attitudes of healthcare workers. So those are the issues that have been brought to our attention by members, which I believe would impact negatively on, the rollout of the NHI.
And may I come in?
Yes, ma'am.
So I want to also bring up this terrible trio, and that is mismanagement, inefficiencies, and corruption. Okay, and I don't have to even go into this. You could just look at media coverage over the years in terms of this terrible trio. Now, if we would want a successful NHI rollout, we actually need to address these canker worms in our woodwork. And until this is addressed, I think the NHI could actually be pie in the sky.
I take that hand on that hand.
Hello, I'm Colleen Quist from VUCA Online Radio. Well done to SAMA. I'm starting to see that you guys are getting teeth. So well done on those teeth. But you're also working from the point of view of bringing in the different factions, bringing in the different silos to sit around the table. So my question is, yes, yay on we can talk. But for so long, South Africans know that we talk, we discuss. We're the best strategists in the world, probably sit here. But how are we going to take the planning and the talking and the discussing into actual action? So that on Monday night or next week after yours, Prof, how's your average Joe, how's your average doctor going to say, yay, SAMA had a conference and we better for it? But so like you look at your three points with NHI, with the unemployed, and with the whole story of criminalization. Come Monday night, people mustn't say, oh, well, SAMA spoke about it. Where's action? You can hear I'm a coach. Not just I want action.
I think if you look at SAMA structures, so SAMA structures has subcommittees specifically to drive most of the topics that we have in the conference to go forward. So if you talk about a criminalization of the medical profession, there's a specific action group looking at that, taking it forward. So this is almost informing where we are, and also gathering information and the feeding on the ground to go forward, because we need to look at a different arbitration system and how you take it forward, because what we have at the moment is not working. Just to highlight one of those topics, and we go from each one of the areas that we've spoken about, how do you restructure addressing, just you said, the talking part is
Yes.
part and parcel of what are the next steps, who's going to take them, and when can we have a report back on this?
Yes, I agree with what Prof. Snyman has said. And what will happen is we will ensure that the conference will not remain as a talk shop only. So whatever resolutions come out of the conference will be directed to the committees through obviously the board of SAMA. And I also want to highlight a new committee that's just been formed in SAMA, and that's the Health Policy, Law and Ethics Committee. And I think a substantial amount of work from the conference will then land on the desk of the Health Policy, Law and Ethics Committee to start taking forward. So we pledge to do that. And we'd like you all to watch the space.
We're going to be.
Just going back to what Yoli was asking, I think there's two critical areas that you need to kind of double click at. One, there's a report that was done by the Health Ombudsman. I think it had 7 questions or factors asked, and hospitals across the country and clinics across the country were requested that I don't remember what it was called, but interestingly, out of that report, less than 20% of the hospitals actually qualified for their own report as a state, right? So the question around readiness should actually really be based on data and not our emotions. That's the first part. The second part is there's a program within healthcare called Ideal Clinic. Have a look at the findings of each audit year on year, and if things are improving. I mean, if you've ever been involved in that particular exercise, what tends to happen is Mzuga's clinic down the road will borrow Theo's clinic staff so that when the auditors come, they actually are passing that particular audit, which actually defeats the exercise. Because if you don't have certain equipment and certain meds, and people are coming to audit you, you need to tell the system the truth so that it's able to fix. So the state of readiness is really up in the sky. And I think that's what our chairperson was saying, that there's this focus on the funding formula, but funding what? If the system hasn't really been, optimized for that particular implementation. Can I take that hand?
Oh, okay. My name is Kodwe Gama from Sunday World newspaper. I'm not too sure whether this question is, related to what she was asking, but Prof. Snyman said something about decriminalisation of the medical profession. And I want to know SAMA's stance on the decriminalisation of, medical errors. Where do you guys stand? And if you've taken any actions towards making sure that actually happens? Thank you.
Maybe I'll start just to say that medical treatment has always got good intent. Medical treatment cannot be divorced from side effects. So unfortunately, if you look at medicine, it's always a risk versus your negative outcome, your side effect. So the more grave the condition, the higher the tolerance for an inappropriate outcome. The more benign, the less the tolerance. Now, if you take that into other disciplines, whether it's surgery or others, the same arguments hold. So some surgeries are very high-risk surgeries. These are communicated with patients before up front. Unfortunately, we sit with often with patients not properly understanding, but we also sit with opportunists within the legal profession that says, well, you have insurance, and therefore this is a moment where we can actually make money out of this particular thing. The fact that it was an anticipated negative outcome, you can't always guarantee a positive outcome. It becomes then the criminalization of the profession. We've seen this in very recent court cases where it's even called murder. That's never the intention, but sometimes death is one of those outcomes, depending on what you're treating at that point in time. And it's, as I've said, it's a global thing. It's not necessarily it's not always local. It's blown over from countries such as the United States, where it's very rife. But South Africa, given its private healthcare and government healthcare, and the legal environment that we live in, it has become very opportunistic to criminalize the healthcare profession in that way. I'm not saying that negligence should not go unpunished. I'm just saying one needs to look at this in a much more balanced way.
I think just maybe to add, the association through its chairperson is also leading an initiative to make sure that the regulator, which is the HPCSA, is actually strengthened. Now, SAMA is of the view that, in fact, the medical and the dental board should actually be a standard law. And that's what the chairperson is trying to regulate, to champion. And it's our view that once that space is also fixed, then you would find that, because these are supposed to be peer reviewed, to make sure that if there's a gap in skill, then that skill is dealt with and the public is protected. So that's the one big thing that we're concerned about. And I think from a business point of view, as the organization, we've also started a unit which we are partnering with I think it's called Mediation in Motion, which is a unit that sits in Cape Town, where we are saying, before even we start talking about the legalistic issues in medical errors, we probably need to engage and see if we cannot find mediation before with the families, because ultimately it becomes a very legalistic thing, and both the profession and the patient ultimately lose. You know, there is, I think it's not proven in terms of evidence, but there is almost like a decline in certain specialties within the medical field, simply because of the risk of doing obstetrics and gynecology, for an example, orthopods and neurosurgeons. Now, the country needs those skills. So we need to just find a way in which we protect the skills themselves. And we believe that mediation would go a long way in dealing with that. So those two factors are what, from a business point of view, what to address.
Apologies for the interruption. There's somebody online that would like to ask a question as well. It's Miamalan.
Okay, maybe Prof. Dai could respond as the chair of the HPN, isn't it?
Yeah,
Yes.
the human rights law.
Yes, yes.
Yes, I think Professor Sneeman has covered quite a bit in terms of the importance of recognizing that any medical procedure, any health practitioner-patient interaction could have some adverse events, some foreseen and some not foreseen. And the importance is trying to get patients to understand. So herein comes the issue of informed consent. And what SAMA is working very hard at is trying to get our practitioners to, in the quest for ethical practice of medicine, to ensure that before any procedure is undertaken, a proper, fully informed consent is obtained, so patients know exactly what they're getting into. Now, having said this, you still have the opportunists who will prey on patients. And unfortunately, when you look at the medical negligence issues that even end up in court, by the time the patient gets a payout, it's very little that they actually get paid out. Most of it goes into legal fees, etc. Now, I'm really excited about the fact that we are piloting our program in terms of mediation. And if you actually go through mediation that's done correctly, we find that there's an over 85% success rate for mediations. And we are hoping that we can actually go that route. Perhaps once we've piloted and we've got some evidence, we can then take this and go to our policymakers and get our policymakers to understand the need for law reform in this direction.
Maybe to just zone in on that, and you probably answer as part of your comment in terms of there's this real situation that Prof. Snyman and Prof. Dyer are touching on, where a judge doesn't get sued for making a wrong judgment. It actually gets reviewed by a higher judge, and people are actually spending years. So it becomes unfair when doctors are being sued. But there's also this real side, which is the syndicate that works with these fake medical negligent cases. And I mean, if you take Eastern Cape, we're spending north of 32 billion. The country's total is estimated at around 100 provision for negligence. And there's a syndicate that includes clinicians, that includes clerks, that includes lawyers. How are we going to deal with the syndicate that actually is fabricating medical legal cases to get the money that Prof. Dyer is speaking about?
Well, thank you so much. The South African Medical Association is working with the South African Law Reform Commission, to address some of the challenges that we are raising now. Because we believe that one, if there's any case of whether you call it negligence or whatever the case is, the patient and the relatives must, get a full understanding of what happened during the procedure. But if you are going to use the approach that we are using now, the accusatory approach, the doctor might want to be defensive, and the system is hiding stuff and all those things. But if you have got a system, a platform that we are advocating for, that is not punitive, a system that allows everyone to tell the truth of what happened, and this must not only be, the burden on the doctor alone, because the doctor is not working in the vacuum, and a doctor is working in a system. There's hospitals, they might have broken equipment, they might have shortages of staff, they might have other things that are not working, there's power issues, so it can be, blame cannot be put upon the doctor alone, when the doctor works in a system. So that's what we want to understand. First of all, secondly, is that platform, it would it wouldn't absolve the doctor, but it improves the system, because now if we've got these transparencies, then we can be able to attend to the weaknesses of the system. But on top of that, we avoid such future occurrences. And at the same time, that platform must give an opportunity for recovery of the patient that is involved. What do we do in the future for this patient? Like we do, for example, in the road accident fund, where we look at how we compensate what is services that we'll be looking for and stuff like that. So it's a platform like that brings in transparency, in the whole system. And so that we improve actually, how we do things, including identifying gaps where we find that perhaps there were shortages or there were deficiencies in terms of our consent, informed consent and stuff like that. So that is where we are heading for as the South African Medical Association. So, but the syndicatism is very important. I think when we get to that point where we've got this that dialogue with the South African Law Reform Commission, I think those are issues that need to be identified and we deal with them accordingly.
Thanks. Can I take the question online?
Yes, thank you. It's Mia Malan from Dekisisa. Thank you for the information about the salaries of doctors. You mentioned that they earn 2015 salaries. I wonder if you could give us an indication as to what sort of percentage salaries need to be increased by to be market related. Maybe you can apply it to the 900,000 per annum that medical interns earn, or the 1.2 million that community service doctors earn. I'm quoting that from Joe Pachla's speech last week.
No, but that's a very easy question because we've done the study and we now know that doctors are earning, I think, 13% less than what they should be earning. We've got a study that we've done, and that's across the board, especially in the public sector.
Sorry, just to confirm, is it 13?
Yes.
Thank you.
Yeah, we've done quite an extensive work there in the public sector. And one of the things that impacted that was the 2020, I think there was zero increase in the public sector. And that just reversed everything that was during the OSD discussions.
But also
Thanks very much.
with the OSD, we actually only ratified the entry level and the very senior level. So you had the junior doctors being moved from a 12,000 rand to a 32,000 rand salary. And then the professors and the consultants also saw an increase that ranged between 15 and 20%. The middle layer, which is the bulk of clinicians, were actually not touched by OSD significantly. There was a very confusing formula of grade 1 to grade 3 MOs that had to be implemented. So we actually are sitting with a 2009 problem, 2007 problem that hasn't been solved. And we're sitting with that. So when suddenly the ministry doesn't have money to pay the current number, we're going to struggle when we're negotiating the future number. Are there any other questions? We did say we'll keep you here until 1. Are there any other thoughts? Okay, any parting shots? CEO, what is your one thing from conference? If we were to ask you what is keeping you awake at night, and this is the one thing you want to achieve out of the conference, can you tell us that as closing remarks?
Yeah, no, I think one of the things that we want to achieve is to make sure that the discussions in the conference, in fact, I think it has been mentioned in this room, they don't only end. So our big thing is to make sure that post-conference, both public and the private sectors with the state, we come together and we develop this blueprint to strengthen the health system in South Africa. That's the main thing that keeps us awake as the association, because we've been talking across one another, and we think it's time for the people of South Africa. We really need to come and talk to each other.
Thank you. Thanks. Should we close there? I think the rest of the stuff you'll get when you come to conference.
Yeah.
Thank you, everyone. Thank you to the summer leadership. Thank you to the journalists that visited us. There's a hand.
Sorry, yeah, I just have one admin question. Sorry. Prof. Dai and Prof. Snyman, what are their positions, or what are your positions at at SAMA?
Well, both of us are members of the board.
Okay.
So
Thank you.
In fact, all of us are board members of some each other. This one is
I know.
an executive director.
I still want to talk to was it YFM, our FM on the youth thing, because we also launching summer students. We can talk about that later outside the conference.
And then another admin question for tomorrow. Do we have clearance? Will security let us in the door?
Yes, you will. You will. I think the media just needs to liaise with our operator first. Yeah, so you don't have.
Are we gonna have parking?
There's the one around that is with the
Yeah.
They're gonna set up
Outside. Okay.
Yes, let me see if I can help you.
I see.
Just for the online people as well, we're done.
Oh.
No, the
Thank
There was
you,
a what?
Ray.
All their minds.
So don't leave with the
I think it's about